Most parts of my presentation you find in the handouts, and the handouts you can get on the desk, the registration desk. So before starting, and we already discussed that, contraindications, written consent, and of course, can the clinical question be answered by using CEUS? Previous imaging study is always important. We don't look at them first, but we look at them when patients bring them with them. Other question, are there cardiac or pulmonary diseases? Especially we ask patients if they have aortic valve diseases, especially aortic valve stenosis or prothesis, because they may destroy the bubbles. The mechanical valves may destroy bubbles and thus interfere with the contrast kinetics. Pulmonary hypertension is very important to know because this severe pulmonary hypertension is theoretically a contraindication. But it has other side effects, as I show you later. Then the side of contrast agent administration is important. We always use the cubital access, venous access, not on the hand or very peripheral. And the kinetics, of course, will change when you have a central venous access, of course. Needle size is important. I will come to that later. Long time existing venous access, so some patients are for a long time in hospital and have a peripheral venous access, so we always test that before we administer our contrast agent. Sonoview bolus plus 10 ml saline immediately after the bolus. This is, of course, a standard procedure. Sometimes, for very special questions, you can also perform a infusion of contrast agent. We now have, and it's just arrived, a pump where two syringes are mounted. One is for the agent and one is for contrast. One is for saline. So when you activate the pump, then you get first the contrast agent as a bolus, and automatically afterwards the 10 ml bolus of saline. So this is a new pump, and well, it looks quite good, and you don't need a second person for the injection. So this might be the advantage. Disadvantage, if you do everything by your own, you have to be prepared, of course, for some adverse reactions. So I always feel a bit better when there's a second person nearby. So, okay, you have to take care of the needle size. We would advise to take needle sizes bigger than 18 gauge. Looking for a port. Port is also important. Some ports have kind of a valve, so that may be a problem with destroying bubbles, but in most cases a port will work. But of course this is kind of a central access, so the kinetics will change. And after finishing the work, you of course have to take care that there's no thrombus within the port. Okay, forearm access, I was already made a comment on that. So bolus question, do you really need a second person, or do you have a pump for that? And, of course, you should be ready for adverse reactions. Biological factors are important. If you have tiny lesions in the liver, you very often will ask the patients, please take a deep breath and hold it. Okay, and if you start with this maneuver before you inject the contrast agent, then the kinetics will change. Because when you look at the patients, then the veins in the neck will pump up. So this is the same that happens in the liver. So the contrast agent will arrive a bit later. And when the patient exhales, then you will have a large inflow of contrast. You have to have that in mind. And of course, I was talking about cardiac diseases. Right heart failure means late arrival of the contrast. Pulmonary diseases is the same. Cardiac and pulmonary diseases mean that you have a different kinetic of the contrast agent. Of course, you should also ask patients, are there any aneurysms, shunts, and especially dialysis shunts. They change the kinetics. You know that the contrast agent has certain pathways in the abdominal vessels. After injection of the contrast agent in the peripheral vein, it passes the pulmonary bed and enters the left heart and goes then in the systemic circulation in the aorta, and then you have a bypass to the liver. The hepatic artery is a bypass, and then the contrast agent fills up the other organs, especially a second capillary bed, that is the intestine, and from the intestine the contrast agent goes into the liver by passing the portal vein. And of course the liver then is the third capillary bed. We have, of course, a definition what means arterial, portal venous phase, and late phase. You can read it in the guidelines, and you know that the arterial phase ends around about 30 seconds after IV injection, a portal venous phase after 2 minutes. It's important because we will discuss later what it means late phase enhancement or how long is enhancement lasting. So this is the definition by the guidelines. And late phase is everything beyond 2 minutes. When you look at the kinetics within the liver, then we visually estimated the transit times and the arrival times. So we did that with, I think these here were 18 healthy subjects, and we compared that to other groups with diffuse liver disease and focal liver lesions. So in normal patients, we have an arrival time in the hepatic artery around about 9 seconds after IV bolus injection, and the portal vein is being enhanced 3 seconds later, so 12 seconds. And the hepatic vein enhances after 21 seconds. So this gives you an idea about the time differences. Time difference between hepatic artery and portal vein is 3 seconds. Between liver vein and portal vein, 9 seconds, and 12 seconds between hepatic vein, liver vein and hepatic artery. You find that in the handouts, these numbers. So this is the control group, and if you look at patients with liver cirrhosis, you see that the arrival time is nearly the same, and a bit shorter in the patients with FNH, and we think that is due to the fact that the patients with FNH are mostly very young. So we also see that patients, when they get older, that the arrival time is a bit later. And in liver mets, also arrival time is the same. But when you look at the liver veins, arrival time in the liver veins, then you see that the liver cirrhosis arrival time was 16 seconds, FNH also 16, liver mets 18. And the transit time means liver vein, or the arrival time in the liver veins minus the hepatic artery. In the control group, as you just saw, 12 seconds. In liver cirrhosis, 6.8, FNH 9, liver metastasis 8.2. And you see that the standard deviation is not very high. So these are reliable, rather reliable numbers. If we look at the liver vein minus portal vein arrival time, then you see that you have in a control group 9 seconds, but liver cirrhosis you have 1.5 seconds arrival time, FNH 5.5, liver mets 4.4 seconds. Just to get you an idea how it looks like when you have a patient with a right heart failure. So this patient has a short angiocarcinoma, and you see the clock is running. You see that the liver venous system is being filled from the heart, so in a reverse situation. And then, and the other last example is a patient with a liver cirrhosis. And just see, this is the portal vein, here's the artery, and now you see the liver vein, and the liver vein fills prior to the filling of the portal vein. Portal vein is still unenhanced, and now you see the first bubbles appearing in the portal vein. So this is due to shunting. This is not an end-stage liver cirrhosis in this patient. This patient had a child stadium of 2 at that time. But you see the kinetics have totally changed in this patient. Okay, here again the still frames after 20 seconds, and this is after 28 seconds. So this is a very brief overview of the kinetics that you should have in mind when you look at the liver. Thank you.